I want to welcome all of you to this special COVID-19 seminar. Many of the talks in our seminar series have been at the cutting edge of research, which is, after all, at the core of what we do at a university, at a research university like ours. However, it'd be a shame if what we did was to research into new stuff and never get stuff out of the lab. Today, we have two exceptional people talking about projects that they've undertaken that have made and are making a real difference in the lives of people and in society. In the context of this COVID pandemic. So our first speaker is Jack Griffin, who's recently graduated from Ross and has started a nonprofit organization called FoodFinder, which has helped thousands of people find food assistance programs. And of course, getting all of this going is a base of data science that underlies this. So I welcome Jack, and we'll have Holly Hartman next after Jack Griffin, and I'll talk about her just before her talk. Take it away, Jack.
Awesome. Sounds good. Thank you so much for introducing me and for having me here. So let me share the screen real quick. Can we see a PowerPoint? Got to make sure it's Zoom law to ask if people can see my screen.
Yes.
Excellent. All right. Awesome. And thanks again for having me and for letting me share a bit about what we've been working on here at FoodFinder. Really, honestly, since 2014, when we began our work, but particularly when, I think we've all, seen the media, heard, apart from, the health ramifications of COVID-19 and the pandemic at large, really right after that, which has been discussed and really a huge issue, are the economic ramifications, especially when that means when, people, losing their livelihoods, when they're unemployed, laid off, even furloughed, then all of a sudden you have people that never had to worry about things like hunger or making their next rent payment. And those are very real issues that really come out of nowhere. So, for the next 10 to 15 minutes, we'll just be talking about FoodFinder's work, a bit about the history of where we were pre-pandemic as it relates to the fight against hunger, and then talk a bit about our specific COVID-19 relief strategy and how we're using data and technology to help people across the country. So, jumping right into it. As I said, talking a bit about where the trends were moving before, really the virus hit America. We were honestly making a lot of progress in addressing hunger and food insecurity at large. Really, interchangeable terms. Food insecurity being the technical term, just meaning that the state of not having the quantity or the quality of food you need to be healthy. So in the 5 years before 2020. Food insecurity in the U.S. had actually declined by 12.5%. That's according to the USDA and all their data they have on that. So we made a lot of progress as the economy was improving coming out of the Great Recession. But it's also worth noting that during that same time in which hunger itself was on the decline, we've witnessed a tremendous upsurge in the number of people who use their own digital devices to search help. So in those same 5 years when hunger declined, Google searches for people seeking help from food pantries increased by 863%, from about 400,000 people per year in 2015 to nearly 4 million people seeking help online in 2019. So definitely even though the need was declining pre-pandemic, certainly where people were looking for this information on where to get help, absolutely moving in the digital direction. So, just elaborating on the role of technology, it is counterintuitive because a lot of people would assume that, if you can't afford food, how would you have a computer? How would you have a phone? And it just really speaks to how smartphones in particular are no longer a luxury in our society. They're a lifeline to live life in a connected world. So since 2015, actually, it's a remarkably consistent 80% or 4 out of 5 searches for help from food pantries have come from smartphones. And it's just been astonishingly consistent every year since 2015. So looking at, from a user's perspective, making whatever solution we make available, mobile friendly, trying to make sure that of course we all, I'm certainly no data scientist, but for anyone who offers information or wants to use data for a practical purpose, then making sure that data and information is digestible and practical for the people we want to help, I think is really important. And that speaks to why and how FoodFinder's work has taken shape as it has today. So FoodFinder itself, we are a 501c3 nonprofit organization. We use both our website, foodfinder.us, and our mobile app, FoodFinder Fighting Hunger, to connect the people looking for help with food assistance to the food pantries, soup kitchens, and other assistance programs nearby that can offer them the help that they need. All since 2014, even when we had our little scrappy, V1 website, it was made native mobile, making sure that it looks good and is very effective on a digital or mobile screen, making that information as accessible as possible. And at the end of the day, we like to say that we want to make it as easy as it should be to find help from the nearest food pantry, because when people search online or for existing alternatives, it's just, information goes out of date super quickly. A lot of contradictory, really, complicated, confusing, really easy to get the runaround through existing search processes. So just trying to take all the hassle out of this process, during a pandemic and before, making it a lot simpler just for people to find the help that they're looking for. So in terms of how this actually takes shape and what, and how we use data, data is everything we do. It's what we're all about. Right now, we have data on more than 50,000 year-round or full-time food pantries, as well as the information of more than 40,000 summer meal programs that are available nationwide, all 50 states, to try to make sure that for any type of free food assistance being offered in communities across America, that they are on our platform and that we can responsibly and effectively guide our users to them is super important. I don't know if you can see it on the screen because of the zoom, like the cameras, but actually you can see on the screen that that's Ann Arbor's food assistance landscape. Backdoor Food Pantry is highlighted on the far right. And even, for instance, we include things like street address, hours of operation, phone number, what services are provided there, what languages are spoken there. Just try to give the user as much information as we can. But even for like the Backdoor Food Pantry, right now it's closed because of the pandemic. So staying on top of those changes is incredibly important. And I'll touch on that in a little bit. So looking at what our work, how it's changed, and the attention that has been paid to food insecurity during the pandemic has really been, awe-inspiring to watch. I'm sure we all see, we've seen a lot of these striking images of, especially when like the pandemic was really ramping up in March and April, huge lines across the country, filling up, school parking lots, stadium parking lots of people all lined up just to get, a bag of groceries or, some free food for them and their family. So it seems obvious, but it's really, you can't overstate how much the need has increased because of the pandemic when it relates to food assistance. So exploring a bit more that now that we know that, pre-pandemic, there were about 37 million people in America who struggled with food insecurity, and that was at full employment. That was like late 2019, early 2020, when unemployment was like 3%. So the economy is doing super good. Still, I'll stand down from my soapbox on explaining why so many people were still food insecure when the economy was so great. But now we know that the earliest estimates of hunger in 2020 is that between 50 and 60 million Americans will struggle with food insecurity. So we have a long fight ahead of us. So in terms of what we're doing, how we're using our information to respond to the pandemic, really two key elements and approaches. The first is that we just have to reach more people. We need to reach people who are newly food insecure, who've been laid off, who during the school year lost access to school meals. Free and reduced lunch, free breakfast at K through 12 schools are vital resources that so many families depend on. So losing that, losing the source of income, it can be catastrophic. So just reaching people who have never navigated this search process before was incredibly important to us. So we use things like Facebook ads, our Google ad grant. We actually, it's actually been multiplied within the last couple of weeks. We get, now we get $30,000 of free Google ads to reach people searching for food assistance on Google, thanks to their in-kind donation, which is remarkable. So reaching people when they're searching for help is amazing for us to reach people and serve them. But beyond just serving more people, we need to maintain as accurate and up-to-date a database on food assistance as possible. The status of food pantry operations are changing at a breakneck speed. So if a food pantry is increasing the number of days that they give out food, if they're decreasing or shutting down altogether, then those changes are incredibly important for us to be on top of so that we can continue to responsibly guide people in need of in need of help who have enough to worry about when they're entering this confusing search process. So that's incredibly important for us. So we need to we need to maintain an accurate database. We do that through our own proactive internal, data verification efforts, going out trying to find these changes. But we also use crowdsourcing, allowing user-submitted edits and updates to our data is for sure in the long term going to be an absolutely crucial step and way in which we continue to offer the highest level of data accuracy possible. Just to give a sense of the impact we've had even during the pandemic itself, to the day, it's actually, this is accurate as of today. We just hit the 100,000 user mark for the number of people we've connected to food assistance during the pandemic since March 1st. That is almost equal to the number of people we served during the entirety of 2019. So to be able to have that level of impact and that level of reach on a national scale, you can see on the bottom of the screen, our geographic distribution. Georgia, that's our home state. That's where our roots are the strongest. That's still our number one. But beyond that, it's just our usage matches up with where the population centers are. California, New York, Florida. I know for Michigan, we're number 12 most used state. So just being able to, reach people in Alaska and Hawaii, and also, serve people in New York City. That's been really cool to watch and really cool to witness as we've been able to just connect the people looking for help with the places that offer it. So finally, as I'm wrapping up, I think just for, of course, for me, where I certainly do not have, in education formally in data science or, anything like that. I'm just, have close to 7 years experience in the application of data in a socioeconomic ecosystem like food insecurity and addressing hunger. Then it's just more about always especially at we all love our research. We all love, our theories, and a lot of the more, academia centric, paradigms as it relates to information and data. But in the real world, it's all about, I'm a huge fan myself of learning by doing, constantly iterating. That's what, especially as we're taught in entrepreneurship, then there's really no substitute for, just seeing your own data or your own hypotheses just get torn to shreds once they're exposed to the real world. But that's how we can offer a better level of service and improve our impact in society. So for our takeaway, for my takeaways, I think as I've just been witnessing what's been going on, data as using data for good. Reliable, trustworthy information and data have never been so valuable. Whether it relates to getting trustworthy information on the virus itself, or on sort of the secondary impacts of the virus, like now I need help with food, now I need help with employment. Having that information consolidated effectively and efficiently is just, it can't be, it's just so important. Second, people can only utilize the help that they're aware of. It's, it seems obvious again, but it's just, that's really speaks to why FoodFinder exists in the first place, is that awareness and knowledge of the information is separate from just having the information itself. So making sure that people are, that you are reaching the people you want to serve. And finally, I'm sure Holly will agree with this absolutely, when she gets into her talk, and continuing in the vein of healthcare as it relates to long-term ramifications from the virus. The fight doesn't end when the pandemic does. The need for food insecurity and really drastic overhauls of the system existed pre-pandemic, and they will exist after the pandemic subsides. So even though as great as the need may be, I'm just fortunate, I'm incredibly blessed that FoodFinder was already in a position to do our part during the crisis and to help out on a national scale. But still, we're in it for the long haul, because the recovery process will be extremely tough and difficult. But we just know that, through the services that we provide, the countless, incredible work of other people and organizations in the fight against hunger, and for every, social and economic need that, public health needs that people are rising to meet the challenge, then that is definitely reason to be encouraged for us, making sure that we can take care of our fellow Americans. So that's pretty much it. Thank you. Thanks for letting me ramble for 15 minutes.
Thank you so much, Jack. Are there any quick questions for Jack before we move on to Holly's talk? And then there'll be plenty of time for discussion at the end. But if there are any burning questions, we can take them right away. Not seeing any. I'd like to welcome Holly Hartman, who's a PhD student in biostatistics and has been working at the Cancer Center, where she's been working with national cancer datasets, and specifically has developed an app called OncCOVID to understand the impact of COVID-19 on delayed treatment for cancer patients. The issue, of course, is there are many impacts. Food insecurity is an obvious one in terms of people don't have work and they don't have income and they're hungry. But there are people who just avoid going to the doctor or getting treated for their cancer because they're afraid of catching COVID. And so there are these secondary health impacts. And I'd like to hear what Holly has done with her app and what she's discovered. So take it away, Holly.
Thank you. I'm going to start sharing my screen. Okay, customary, everybody can see. Okay, good.
Yes.
Yeah, today I'm going to be talking about the app that we developed, talking about when treatment should be given for cancer patients during the COVID-19 pandemic. And here's some contact information. I'm trying to be more active on Twitter, so I thought I'd put that there. And then before I get started, I just have to thank so many people for all of their help on this app. I'm honored to be representing this team today and talking about the app, but this really was a huge collaborative effort to get this out and going in just a short time span. A lot of people from the biostatistics department, radiation oncology at the hospital here, and then we had some collaborators even at Penn State. So cancer and COVID-19. So as in my introduction, cancer patients are at an increased risk of COVID-19 mortality, meaning that if they get COVID-19, they have an increased probability of dying from that disease. And unfortunately, going to the hospital actually increases the risk of contracting COVID-19 because the patients are interacting with more people and have more potentially infectious contacts at the hospital than they might if they were staying home. However, delaying cancer treatment is also not a great option because that gives the cancer time to spread and can increase mortality in that way. So balancing those risks is really important for cancer patients during this pandemic. Additionally, there can be trouble with the actual treatments that cancer patients are receiving. So immunosuppressed people are at increased risk for COVID-19 mortality because they don't have the immune system to fight off that infection. And chemotherapy, which is a common treatment for cancer, makes people immunosuppressed. It wipes out those the immune system of the people receiving it. So that puts people at even further risk for dying of COVID-19. And even surgery requires ventilation, which can increase the risk of contracting COVID-19. So from the disease that these people have and the other comorbidities to the treatment that they're receiving, these people are at really high risk for COVID-19. So the big question that is being asked among oncologists, but even the patients themselves, is how do we treat cancer patients during the COVID-19 pandemic? And this question has been on a lot of people's minds. These are some big news stories that were put out in the popular media, even in non-scientific contexts, where people are asking, how do we treat these patients? Currently, people are using these tiered systems to make treatment decisions based on the cancer's type, where it's located in the body, and the stage of the disease. So they're assigning people either treat immediately, delay treatment short, or delay treatment indefinitely based on just the cancer type and stage. But these tiered systems ignore a lot of really important factors that go into COVID-19 mortality, such as if the patient has other comorbidities, the geographical differences in the state of the pandemic. Someone in New York City might need a different treatment timing than someone who is in rural Montana. It ignores the patient's age, whereas the age is really important with COVID-19 mortality and cancer mortality. And it ignores the treatment plans that the clinicians are setting up. So in response to this, myself and all of my collaborators worked together to develop this OncCOVID app. This is a web-based app that clinicians can use. It has a bunch of different inputs that the clinicians can adjust, as well as some defaults that we have collected from the literature and information about that. And then it outputs personalized infection risks, mortality risks, survival curves, and other survival data. And this is currently located at oncovid.med.umich.edu, and you can play with the app there. So I'm going to talk about the some of the underlying math and the data science part of things that it goes on behind the scenes for this model and how we created this. So there were 4 really big pieces of information that we needed to get these individualized survival estimates. The first one is that we need the estimated cancer mortality if the patient received treatment right now. So this is just the standardized cancer mortality that we would have pre-COVID as well. And then we need to estimate cancer mortality under delayed treatment. So what is the effect going to be of if we delay this person's treatment 3 months? And then we needed information about the COVID-19 infection risk. What is the probability of the person getting it if they stay home versus if they go to the hospital? And then the mortality risk. So to start, I'm going to jump in with the cancer mortality under immediate treatment. So we used data from a very large population registry database called SEER, Surveillance Epidemiology and End Results. And this tracks cancer cases across the US. And so we estimated survival based on age, cancer type, and cancer stage here. And for that, we used the Cox proportional hazard model. And then we also looked at cancer-specific survival, and that we used the fine and gray regression. And this type of regression accounts for competing risks. And so what that means is patients might die of their cancer, or they might die of something else. And so if a patient dies of something else, then they can no longer die of cancer. So this type of regression accounts for that competing risk of other cause mortality in it as well. And then we needed to estimate the effect of delaying a person's cancer treatment. And for this, this is where our collaborators at Penn State came in. They used the National Cancer Database, which is another large cancer population registry. And they estimated the effect of delaying the cancer type by stage and by the disease site. We also looked through a lot of literature to try to find estimates of delaying treatment. And then we have both the results of our literature review and the Penn State analysis available in the app, so people can see these results and plug in what they think makes sense for their patient. So for the cancer mortality under delayed treatment, our collaborators used a multivariate Cox proportional hazard model. And there they were able to adjust for a lot of different confounders like age, race, insurance status, and even the facility type of information, if it was an urban location or a rural location. And there they ended up with this hazard ratio for a per day increase by disease site and stage. So what a hazard ratio is the effect of delaying cancer treatment by 1 day, what the effect is on the overall mortality. So with this hazard ratio estimate, we were able to take the cancer mortality under immediate treatment and then multiply it by this hazard ratio to come up with cancer mortality under delayed treatment there. So this is based on how long the patient is, or the clinician is planning on delaying the treatment, and stage, site, age, and it takes all of this into consideration to come up with an estimate for survival under delayed treatment. The next big piece that we needed was COVID-19 infection risk. So this is where some of the epidemiology that we're hearing and learning about a lot comes into play. So there's a model called a susceptible infected recovered model, or a SIR model. And that that is sort of the transition each person in a population can go through during an epidemic. So everybody starts out susceptible. You can get this disease and become infected. And then some proportion of the people will then become infected with the disease. And infected people can spread the disease as well. And then after some time period, you're recovered. And in this model, you assume that people who are recovered can no longer become infected and can no longer spread the disease. And as we learn more about COVID-19, there is many hypotheses about these different stages. And so we used this simple model, but in future work, we're aiming to try to make this a little bit more nuanced, to account for asymptomatic people who might be spreading the disease, and potentially people who were recovered and maybe they are able to become infected again if the disease mutates. So that's the basic model. And then there are different proportions of people that transition each day. One thing that we did a little bit different from this base model is that we modeled the healthcare system separately from the general public. So we know that healthcare workers are at an increased risk for contracting COVID-19 because of the number of contacts that they have there. And we've seen data that healthcare workers are a significant proportion of the people who have become infected with COVID-19. So there's an increased transmission rate. So the probability of going from susceptible to infected is higher for people who are in the hospital and healthcare workers. So then we assume that patients have that increased transmission rate if they go to the hospital. And then also we have an increased infection rate due to surgery as well. So one of the important numbers here is called the reproduction rate. And this is kind of the hot topic for like flatten the curve, slowing the spread. And this number is the number of new infections caused by one person. So there's R naught, which is just the base number, the number of new infections caused by one person in an entirely susceptible population. And then RT is how that number changes over time as people become immune to it, as we are implementing social distancing, how this number changes. One interesting study reported that China saw the reproduction rate drop from almost 4 to 0.32. So if that number is greater than 1, then you're having an increase in infections. More people, one person is causing more than one infection. And if it's below 1, then you're going to see a decrease. So this reproduction rate drop is very significant and shows the impact of social distancing and the other measures that we're trying to implement right now. So I have a little bit about the SIR model, but I think I'm going to gloss over some of this. But basically, the different parts of this SIR model, so there's the population size, N, the number infected, and the number recovered or removed, and the number susceptible. And these numbers, so I, M, and T all need to add up to the population size. That we are assuming that people are not being added to the population or being removed from the population, although there are extensions of this model that do allow that. And then we have the RT value. D is the duration of infectiousness. This gamma is the rate of recovery, basically, and it's 1 over the duration. And then beta is the transmission rate, and that's a function of the reproduction rate and the duration of the disease as well. So this is a plot that we're all becoming quite familiar with. This is the curve that we're trying to flatten. So this red line is the number of the proportion of infected people in the population. This blue line is the number susceptible, and this green line is the number that are recovered. So you can see that the number susceptible is always decreasing, the number recovered only increases, and then infection has a peak and then declines. So in the multi-setting model that we use, where we allowed that beta, the transmission rate, to vary between the general public and the healthcare setting. And so we essentially modeled the healthcare setting separately from the general public and then assumed people can move between those two settings. So we have these different populations, so these subscripts. So this is S, this is the number susceptible, G is for the general public, T is for time T, and then the number susceptible, H as the hospital at time T. So we have the susceptible, infected, and the number of new infections have the same subscripts. So then we can estimate the probability of a person becoming infected based on the number of new infections in the general population, the number of new infections in the healthcare system based on if they come into the hospital or not, and then the number of new infections due to surgery based on if they had surgery or not. So this PT and this UT are based on if the patient is coming in for treatment on that day and if the patient is having surgery that day. So we can add this up and come up with the cumulative probability of a person becoming infected. So that's how we estimated the COVID-19 infection risk. Now for the COVID-19 mortality risk. Our goal for this was to come up with a more personalized estimate for COVID-19 mortality than simply a global estimate or something for patients with cancer. we wanted this to be based on the person's age and the number of other comorbidities that they have. So we know that the mortality rate increases for as age increases, and we also know that it increases with the number of comorbidities a person has. However, as you might expect, age and the number of comorbidities or other diseases a person have are correlated. As you get older, the number of other diseases you have also increases. So we needed to find COVID-19 mortality rates, taking all this into consideration. So we had data from COVID-19, that was a case control study. Then we have NHANES, which is basically a population sample of health in the United States, and that is available, open access for anyone. And then we also had a large study that had mortality rates by age, but it didn't have mortality rates by age and number of comorbidities. So to get at the numbers that we wanted, we used a constrained logistic regression to get estimates of mortality by age and comorbidities. And this was just to ensure that as age increased and as comorbidities increased, the mortality rate also increased. We adjusted for the design type, case control. And then we standardized this using the NHANES data and the large study. So here's the estimates that we were able to come up with for age and number of comorbidities. So you can see that these follow the rules that we had set up, where this increases with number of comorbidities and with age. And then we also took into consideration if the healthcare system is overwhelmed, that also increases COVID-19 mortality, as well as if the person has chemotherapy. Another factor we wanted to take into consideration is the geography and the specific state of the pandemic in a person's local region. So we use Johns Hopkins data, which is publicly available on GitHub, and that has daily COVID-19 data by county, by province, or by country. And then we used US Census information to get the population estimates for each county. And we use World Bank estimates for non-US countries, states, or provinces. So we were able to use the actual information of the local pandemic state to estimate the state in which that particular county is in the pandemic. So if a county is at the very beginning stages of a pandemic, then delaying cancer treatment might make it so that you're actually treating the person in the middle of the peak, which you wouldn't want. Likewise, if someone's at the peak, then and you're going to treat them right away, then that would be not good. You'd want to delay that a little bit. So that's how we incorporated the geographic information. And then our final outcome that we were most interested in is called restricted mean survival time. So for a person, we were able to estimate a survival curve, which I have a graph of right here. This line starts at 1 and ends at 0 in this case, but it could be something that plateaus around 0.5 or even less than that. And then the restricted mean survival time is the area under this curve. So it's basically just summing up that space. And this is an alternative to using a hazard ratio, and it works when you don't assume that the hazards are actually proportional, which is an assumption for a Cox proportional hazard model. And so I'm going to show some simulation results that we have now for this app. So we plugged in different kinds of patient data, different ages, different stages, and we assumed that the person was in Washtenaw County. And so for this, we have the different disease sites, and we have the difference in RMST based on immediate treatment or delayed treatment. And you can see that within each disease site, there's a lot of heterogeneity. It wouldn't be possible to come up with some sort of simple rule saying this person should receive treatment and this person shouldn't, because there is so much variation here. Similarly, we looked at each person's, how they would be assigned a tier based on the tier system that we're trying to replace. And you can see that there's a lot of heterogeneity here. So tier 1 is no delay of treatment. And you can see that there are still patients that favor delaying treatment here. So these tiered systems aren't very nuanced with that respect. Then we also looked at patients across the country, and we looked at if they would favor delayed treatment or immediate treatment using our models. So red means that it favors delayed treatment, blue favors immediate treatment. And you can see that, for example, bladder stage 2 cancer has geographical variation in some of the hot spots like New York and New Orleans. Delaying treatment is favorable, whereas other places immediate treatment is favorable. Similarly for oropharynx stage 3 cancer. So one peculiar thing that's happening here is the lung. At first, it slightly favors immediate treatment, then it very much favors delayed treatment, and then it goes back to favoring immediate treatment. So what's happening here is that the effect of delaying treatment is having a really big impact on the survival estimates. So this is delaying 1 month, and you can see immediate treatment and delayed treatment are basically right on top of each other. So a 1 month delay is essentially equivalent to having immediate treatment. And then for a 3 month delay, the immediate treatment stays the same, but delaying treatment, at first it has a benefit and then it has a negative effect. And then if you delay it 6 months, it is not good. So immediate treatment is more favorable than a 6 month delay. So these are types of information that we can get from our model and our app. The next steps that we're going to take are updating our survival estimates. Right now we're using that SEER information, but unfortunately we're currently overestimating survival for elderly patients. So patients who are 85 and up, we are estimating that they have a higher survival probability than what we are actually seeing. So calibrating that will be important. We also want to update our model for delay of treatment to better account for age. And then the SOAR model that we're using, we'd like to start automatically incorporating some of the historical trends a little bit better using that Johns Hopkins data, as well as community actions such as social distancing and taking that into account, and then introducing some randomness so we can sort of see how the variation that we might see in reality. And then using that, building on that, we want to try to account for the uncertainty. All of these are based on estimates, and all of this is based on data that is rapidly changing. We're learning about COVID-19 as it's happening, and so a lot of new information is coming out daily about this. And so staying on top of that and taking into consideration that a lot of this data is new. There's not a lot of data out there. We have wide confidence intervals, and incorporating that will also be very important. And that is what I have. Thank you all so much for attending. I do have some references here as well to sort of show where all of our data came from. So thank you.
Awesome. Thank you so much, Holly. Here, I'll get my video turned back on as well. So I think that leaves us with a good chunk of 14, 15 minutes where we'll be able to do any Q&A if anyone in attendance has any questions. We're going to leave this pretty open where you can either put it in through the Q&A system, put it into the chat, or feel free to raise your hand. I can unmute you, ask you to ask your question out loud. Now, Jack, I saw that you responded in the chat to one question from Jing, and I think I'll just have you answer that one again, just so that we've got it on video as well, if that's fine. So I'll read it back out loud.
So from Jim, we had a question. How do you grow users of the app? Have you seen or do you anticipate resource allocation issues? For example, if a certain area suddenly has a lot of users, but the number of food service programs is fixed, will certain programs get overwhelmed? Is there any way to redirect traffic, or would it be feasible to get data analysis for things like this and to make the app smarter? Oh, Jack, you're here. We'll get you unmuted again.
Yep. Yeah.
There you go.
Yeah, those are all terrific questions. The first one's easy. Like marketing and awareness are actually my favorite thing to work on for FoodFinder. So, traditionally we use both offline, for offline awareness, we anchor ourselves to the education system, especially public schools, K through 12, really great institution to be a part of, to partner with, and to reach both, students on free introduced lunch as well as their parents. But right now, digital marketing is really where all our awareness is coming from, as well as just organic, growth or word of mouth. But for really the sort of the main sort of like the meat of that, of the questions overall, being matching supply with demand is an incredibly relevant and almost impossible to answer question, because for us, for the first part, it absolutely that in March, that's when, for instance, for us, right, just for the number of users we see on our website, precisely on the day, March 13th, that the United States declared COVID-19 a national emergency, our usage went from 700 people a day to 3,000. And that was actually almost identical to the in-person growth in volume that food pantries witnessed across the country, of either doubling, tripling, or quadrupling their normal number of visitors who attend to pick up food. So matching supply and demand, that's why we're actually we love that we use a map, because not just with a huge list or a spreadsheet of resources, you can actually see the concentration or the density of food assistance providers in relation to one another, and in relation to the population centers, whether it's urban environments with huge number of people and a huge number of providers, or in rural settings, where rural hunger is especially challenging, because that's where oftentimes the proportions of the percentage of people in need are the highest, but that's when the number of resources are the fewest, and things like transportation really emerge as barriers and other hurdles to overcome. So matching that supply and demand is arguably one of the most influential end results of FoodFinder's work in the super long term, where that can inform policy decisions, that can inform where new food assistance providers set up shop across the country. Just indirectly giving people options, showing people every food provider nearby, like within 5 miles, or we default to using people's current location. We want to give people options so that we're not just sending thousands of people to one resource, but of course our usage is so spread out that that's really never been an issue. That is certainly there are actually some other organizations trying to tackle that exact challenge, like a map, like a heat map of which food pantries are good for food or are really overwhelmed in terms of what percent of utilization are they at. That's so impossibly hard to actually do at scale, though, just because of how fragmented the landscape is, and the reporting issues are just that's something that's we're FoodFinder staying in our lane. We just go straight to users and let them, and we want to show them where when and where food is being given out, but certainly we would love to help solve for that in the future.
Brilliant. And just kind of taking a look over everything, seeing if anyone's got hands raised or if there's any questions coming in. Because I have an almost off-topic question that I don't want to dig into if we're still got specific COVID-19 questions and everything as well. So I'll hold on to that for a minute or two here while we let people come through with anything. Here, we've got another question for Holly. So Holly, are you working with clinical teams / community health workers interested in adopting your app in their clinical work and patient monitoring? How can this become a patient education tool? How can something like this be expanded in the future so it becomes a more general use health monitoring tool?
That's an interesting question. Right now we're working with just the Michigan radiation oncology team. And the idea is that this app is more clinician facing, although it is open access or available on the web, so patients can currently access it. Anyone can. I think that for this to become a patient education tool, sort of to understand their own personal risks, I think that we would probably want to potentially provide a little bit actually less information, because we have this tool being so incredibly flexible. We actually have some advanced settings that people can change, so it's very easy to, if you think some value is different than what we assume it to be, you can go in there and change it. So everything is changeable in the app. And so you can get kind of scary estimates for survival based on what you put in there. And so it could potentially, if it was widespread in its current state used by patients, could cause a lot of unnecessary fear. So I think that making it definitely simplified, scaling it down, and then outputting more general tips rather than like your estimated survival is, 87%, rather than those specific numbers, would be a great option for that. And then expanding it so that it becomes a more general health use and health monitoring tool. I actually really like this idea. Right now it's very, very set up for cancer and oncology, and looking at the risks of those types of treatments. But I think as this pandemic continues on, people are going to want to know, people with other conditions are going to want to know their risk of going into the healthcare system. Should I get treated for this? Should I wait? And so I think that to expand this, we'd have to remove some of the assumptions that we have and some of the specific things. Like one of the checkboxes we have is, are you going to be giving them chemotherapy? And that's not really a relevant question for not cancer patients. So adding different options, maybe having a drop down for which disease or what treatment you're going in for, if it's more of an inpatient thing or an outpatient thing. But I think that those are, now that we have the basic framework, I think that all of those are totally feasible and would definitely be worthwhile. So those are all fantastic questions.
Awesome, thank you. All right, well, I'll ask my off-topic one just because I'm curious then. So Jack, this is a question for you. Since you had mentioned that the first day that COVID-19 was declared like a national pandemic and you saw an immediate spike in both usage and data, I'm wondering if more recent events have also had almost like a similar impact. My hometown is Minneapolis, Minnesota, so after the George Floyd killing and when those protests really started taking off, I was hearing a lot of news and talk about grocery stores in areas being looted and burned, obviously not open, which I think dramatically increased food insecurity in those neighborhoods, whereas they may already, be suffering from food insecurity, having only limited options. I guess, did you see any spikes either from your data that you have in Minnesota or elsewhere in relation to those types of things that you can attribute?
Yeah, no, that's interesting. I'm pulling up my analytics now. I haven't seen anything to the effect that you're describing in our data right now. Of course, we're just one, resource of many, and our analytics are, affected by other factors, just such as, like our ad budget, and that's why, and just our reach in different parts of the country. So like that's why Georgia is sort of atypically, more used than other states. But that does bring up a fantastic point of sort of the relation between just normal, access to groceries and food and food supplies, just during a normal time, as well as the supply of food assistance and groceries and shelf-stable items that are available at food pantries. To where that's what we've noticed. I unfortunately do not have any hard data to back it up, but just in our sort of viewed experience, then there is often a very high correlation between traditional food deserts, where there is a lack of affordable groceries or grocery stores in a community, and basically food deserts often correlate to food assistance deserts, to where there can be a distinct lack of food assistance providers. A lot of times the majority of food pantries in America are operated out of faith-based institutions, such as churches, mosques, things like that. So a lot of times it's just a very informal local effort that rises to meet the need. So especially in cities like Minneapolis, let me actually, I'm still looking at our data for the city overall. Doesn't look like our usage has been affected that dramatically, especially as it relates to the pandemic, food insecurity, and issues, all the issues surrounding race, and some of the riots that have been taking place in the last few weeks. But that really all goes to show that it's all interconnected. Public health, social inequalities, true economic issues like unemployment and hunger, also all sides of the same coin. So that's where, of course, FoodFinder being very specific, very niche, if you will, but that's just to make sure we can focus on what we can have the same quality of service on a national scale. But that goes to show the importance of a holistic approach in dealing with these solutions, so you can be conscientious of all the different factors at play in 2020 is just a wild year. So this is certainly, I can't remember the last time when it's been so visible that, there are so many complicating factors.
Brilliant. Thank you. All right. Well, we're at 2:00 now. So I think unless we have any last minute questions coming in, I think we can call this a good stopping point. Wanted to thank you both so much just for taking the time and presenting. This is really interesting. And looks like Jane has some words she might want to say as well. So
no, I just want to thank you both for the wonderful presentation and the wonderful work behind this. It really shows how the Michigan students are making a real difference. This will be recorded and we'll post it online for more people to view. Thanks so much, and thank you everyone else for attending the seminar with us.
Yes, thank you for inviting me.
Yeah, thank you.
absolutely. Well, everyone stay well. Have a good rest of the day.
Have a great one.
Yeah.